Good afternoon, ladies and gentlemen. I was about to say buongiorno a tutti, but in this rather empty hall this sounds a bit overdone. Nevertheless, I'm very pleased to be here, and I think it is a very important topic that I am about to tell you more about. But before doing so, I owe you this slide, after which I first have to say a little about the theme of this conference, bridging gaps. Now, I hope that in the presentations Rutger Jan and Patricia gave, the issue on gaps between addiction treatment services throughout Europe and other fields of health services really do exist. And I don't need to go further on to that, but there's one more thing that I would like to say. Yesterday, Tim Willens gave in this arena an excellent presentation, and I think there were a bit more people than now. About at least 200 were gathered, and he asked how many of the persons did treat adult ADHD. And I think that only 10, 15 raised their hands. And I think that's a bit sad, for in this conference, where there is so much knowledge, so much experience on how to treat child and adolescent mental health issues, that the most related field is so little present. And that is one of the reasons where we have to do something, where we have to work hard on. One more issue related to these gaps is a topic where Patricia already talked about, and it is the way in the general public, but also in professional institutes, is viewed upon disorders like substance use disorder. Rutger Jan told you that I have been working in an addiction treatment center. I did so for 13 years, and one of the things that struck me when working there was how people with these disorders are viewed upon. They are often blamed for having a disorder, and it goes like, hey, when I have the ability to stop smoking, why can't you? And if I have the ability to control my drinking habits, why don't you? And in fact, what we are saying with this is that having this disorder is only a matter of will, a matter of motivation. And I think that is very sad, for we shouldn't blame people for having a disorder. Now, I'm going to talk about ADHD and substance use disorder, and it is striking that with ADHD, very much the same thing occurs. In my view, most ADHD children, adolescents, and adults hear their lifelong the same sentence: you can if only you try harder. And it's striking that both ADHD and substance use disorder patients do hear this. And I think we should stop blaming patients for having a disorder. Having said that, I will come to the project that we did in the Netherlands, aiming at the development of an intervention program for ADHD and substance use disorder. We wanted to know, is it true that this disorder is very common in this specific population? And if so, how to treat, and how to diagnose and how to treat these patients. And after finalizing the project, we found out that they do occur, these patients do exist in the addiction treatment centers. It is very important to think about the consequences of this finding. What does this mean for other fields in the health services, and what does this mean in your field, child and adolescent psychiatry? Now, when starting with our project, we had to be very careful, for there was a lot of debate in our country going on, not only about the concept of ADHD. In the general public, it is very much viewed upon as, hey, an American trend, and we shouldn't go that way, that so many people get stimulants for this disorder. There was still very much debate on the concept of adult ADHD, and when thinking of probably giving stimulants to these populations, well, beware, that is real tricky business. And when you look at this cartoon and you would change the name of the Child Behavior Clinic for Addiction Treatment Center, you can imagine that we wanted to be very keen on how we described the procedures for both diagnosing and treating this subgroup. So we started our project, which ran from 2000 up until 2004, with the establishment of an expert panel in which a variety of disciplines were gathered. This expert panel developed the first concept of the intervention program, and it did so based on a rather thorough literature review and based on their own experience and knowledge in this field. After this development, the intervention program was tested in 2 large addiction treatment centers in our country. Now we had 2 major goals with our project. First of all, we wanted to develop tools for our professionals in the addiction field for diagnosing and treating this group. And second, we wanted to have a hint of the scale of the problem. We wanted to have an estimation of the prevalence in this specific group. The intervention program we developed and tested consisted of 3 important topics. Screening at the front door of our addiction treatment centers. When positive on the screening instrument, the patients were referred for a very thorough diagnostic procedure, and after being diagnosed with ADHD, the patients received treatment, and this treatment consisted not only of medication but also of psychoeducation and coaching. Here you see a picture of our country divided in 13 regions, and each region has its own addiction treatment center. And before 2000 there was hardly any psychiatrist who did experiments with diagnosing and treating ADHD within the clinic. Now this was the first part of our project in which we trained staff of the addiction treatment centers for doing the test of the intervention program. It was aimed at the screening and diagnostic treatment for outpatient patients, but the treatment we would only give on an inpatient basis because of the fact that we wanted to be very sure that patients would take their medicines on a regular basis and that they couldn't misuse their medicines. But we soon found out that this was very difficult for the majority of our patients who received diagnosis ADHD did not want to go to the clinic for this treatment. So in the second phase of our project we had to broaden the intervention program. We did this with the same procedure. The expert panel developed the concept. It was tested in the same 2 addiction treatment centers, and after evaluation we refined the final intervention program. After the completion of the intervention program, we implemented the program in 3 other addiction treatment centers, and we finished that process in 2004. And as you look at the situation in our country now, not only due to the things that we did, but also in relation to the general attention for adult ADHD, you see now that in almost all of our addiction treatment centers there are activities on diagnosis and treatment of ADHD. Now one can ask, why so much attention for this particular disorder in this field? As Patricia just pointed out, there is a wide variety of severe other psychiatric diagnoses. Now I think there are three answers for that question. In the first part, it proves to be a very, very common disorder. In our study, we found a percentage, an estimate of the prevalence of 18.2, and that means that almost 1 in each 5 patients of our addiction treatment centers does have ADHD. Another striking finding is that it seems to be that a lot of those that are diagnosed in the addiction treatment centers now never had been treated for ADHD before. And I think that is something to really think about. And the third reason, of course, is that ADHD proves to be treatable in children, it proves to be treatable in adults, and at this point in time it is questionable whether it will be treatable in this specific group, but we have to find out. Now, what do we have at this point in time? An increasing awareness of the disorder in our addiction treatment centers, which leads to an increasing number of patients getting properly diagnosed and treated. But we are far from the point that every patient who does have ADHD gets this diagnosis and gets the treatment he needs. We know that a lot of these patients not only have ADHD and substance use disorders, but also have other comorbid disorders. And what we achieved is that a lot of personnel of the addiction treatment centers received training or receiving training in this disorder now. But when you look closely at the situation, not only in our country, but I think worldwide, is the fact that the evidence for diagnosing and treating ADHD in this specific group is really very, very thin. It seems to be not very popular to do research in this field, and it is hard to get funding for activities in this area. So we lack evidence for a lot of procedures in this specific group, and that is something we should do something about. Back to some figures. I think it's no longer questionable that ADHD is a disorder that does persist into adulthood. It isn't a disorder which will simply disappear when going from adolescence to adulthood. And I think that both studies in the Netherlands and studies in the US prove that. Now, Tim Willens did very important work together with the group of Mr. Biederman in Boston on this subject, and I have some of his materials put in this presentation. And he looked at how many times does substance use disorders do occur in adult ADHD patients. And he reviewed the literature and he found striking figures. Lots of alcohol abuse and dependence, high figures of drug abuse and dependence, and based on the specific populations, based on the methods used in the research, these figures vary. Now the same thing goes for the other way around, ADHD in different subgroups. And when you look at the lowest row, you see prevalence rates which are really striking, and one may question the 71. I do not know which study that is, but it most certainly is a very specific group. But nevertheless, this lowest row shows clearly that there is something going on. Not only in studies from the Boston group we know that this is true. Work from our colleagues in Spain, Professor Casas and Tony Ramos Quiroga, they did a study in their population of adult ADHD patients. They compared 406 ADHD adults with 89 controls, and what they saw both in lifetime SAD problems and in current SAD problems, striking figures of SAD problems. Our colleagues from Norway, Eva Løvhaas and Arvid Skutle, are doing excellent work in the Bergen Clinic Foundation, an addiction treatment center. Norway has a very strict policy on diagnosing and treating adult ADHD, most certainly in addiction treatment centers. So they had some sort of a hard time of getting prevalence rates, but what they did do is a study on 29 patients very thoroughly diagnosed with ADHD, and they investigated the number of problems that patients having both of these disorders often have, and you see a wide variety of different problems. And the reason why I also show you this slide is the last sentence. They also found that in this group a very huge majority had not been diagnosed with ADHD during childhood. And like I said before this audience, that is something to think about. In the Netherlands, we also found striking figures. The study Patricia told about 18.4%. In our study, 18.2%. Almost 1 in each 5 patients does have ADHD. And again, a lot of them never have been diagnosed or treated before. One more slide from the work of Tim Willens. ADHD proves to have a rather worrying effect on the course of the development of the disorder. It proves that ADHD adds to an earlier onset of substance use, and it proves to add to what we call accelerating of transitions from use to abuse to dependence. When ADHD is there, these transitions go much quicker. Transitions from one drug to another drug, when ADHD is at stake, these transitions go much quicker. And Willens also proved that remission, so no longer fitting in the DSM criteria for substance use disorder, when ADHD comes in, it is much more difficult to get in remission and in fact being healthy for that disorder again. So this is really, really worrying. Now, what is important is to look at which ADHD child, teenager, adolescent does follow a development through to adulthood without the development of substance use disorder, and which patients do follow a pathway to SAD problems. And there has been done a lot of research on this issue, and it is commonly known that ODD, conduct disorder, antisocial personality disorder very much add to the risk of the development of substance abuse problems. And of course, genetics play an important role, but it also seems to be the case that ADHD in itself is a risk factor for the development of substance abuse problems. Now, what puzzling me is where I have put it the question marks. What happens at that point? What are the risk factors involved for going to one of these pathways? And if we are able to detect those risk factors, what can we do about it? And what can we do to develop prevention methods? When thinking about the figures I gave, in the Netherlands, addiction treatment centers serve 40,000 patients on an outpatient basis yearly. 1 in each 5, this means that almost 8,000 a year do have ADHD. And then we are talking only about those referred to the addiction treatment centers. Those with ADHD referred to the mental health services are not in that figure. Those not going to one service at all, but do have both disorders, are also not in that figure. So when talking about the Netherlands, we are talking about thousands of patients who having both of these disorders, raising very, very much troubles in a variety of aspects of their lives, not only for themselves, but also for their families, and if they are occupied in work, for their colleagues, and so on and so forth. Now this gives an enormous potential for treatment possibilities. It also gives an enormous potential for prevention of substance use disorder. For right now, a lot of patients you treat and a lot of patients you do not treat at this point in time are on their way developing substance use disorder. Now if this goes for the Netherlands, I hope that you wonder what this means for your country and for the service you are working for. This means that we have a lot to do, and that is why the Trimbos Institute initiated both on a national and an international level collaborations. And the international collaboration on ADHD and substance abuse, ICASA sets up some goals in which we hope to address the problems that I talked about in this presentation. Now we have some research planned. In October we will start a controlled trial with methylphenidate in adult patients with both ADHD and SAD. We hope to start later on a long-term randomized controlled trial, and with our international group we think we can start in January with a huge international prevalence study in which 6 to 11 countries will participate. Together with our colleagues from the Columbia University, we will do a study on prevalence and genetics, and we have several other studies in our plans. ICASA now consists of 12 countries, about 30 researchers are involved, and I think that we could use some experts on child and adolescent psychiatry, for we have a lot of gaps to bridge. If you want more information about the topics I spoke about or ICASA, you are most welcome. And this ends my presentation. Thank you for your attention.